Welcome, colleagues. Today's explainer distills the newly updated 2024 RCOG Green-top Guideline 69 on nausea and vomiting in pregnancy and hyperemesis gravidarum. We've taken this massive update and completely transformed it into a high-yield clinical pathway that is perfectly structured for your MRCOG prep. Look, if you're gearing up for your exams, you know that guidelines evolve, and this one, it contains some absolute practice-changing updates that examiners are going to love to test you on. Here is our clinical roadmap for today. We'll cover pathophysiology and definitions, diagnosis and clinical assessment, ambulatory care and antiemetics, inpatient and refractory management, and finally, complications and ongoing care. Let's get right to it.
All right, starting off with Section 1, Pathophysiology and Definitions.
Okay, there has been a massive fundamental breakthrough in how we understand this disease. For your exams, you absolutely have to know about the discovery of the vomiting hormone, GDF-15. This is a placental hormone that literally drives the loss of appetite, taste aversion, nausea, and weight loss. Genetic variants associated with its expression in families are now identified as the single greatest genetic risk factor for HG. This is a total paradigm shift. Now, this is important because it completely busts a classic exam miss. For years and years, we were taught to just blame HCG. But while it's true that both hormones peak early in pregnancy, the higher circulating levels in HG patients are definitively tied to GDF-15. Large studies have actually found zero genetic variants in HCG associated with HG. So when you're taking your MCQs, remember, HGG is just the decoy. GDF-15 is the real answer. Shifting gears to diagnosis, we now follow the international consensus Windsor definition. Pay close attention to what's emphasized here and honestly what's missing. The guideline deliberately moves away from strict, historical, objective measures, like a specific percentage of weight loss. Instead, it leans heavily into highly subjective, patient-focused criteria. We're talking about the inability to eat and drink normally, and symptoms that severely limit the patient's daily activities of living. Moving right along to Section 2, Diagnosis and Clinical Assessment. So, how do we accurately assess severity and, more importantly, catch those dangerous red flags? Well, keep in mind that normal NVP usually starts between 4 and 7 weeks and resolves by week 20 in about 90% of women. If a patient comes in with new onset severe vomiting after 16 weeks of gestation, you have to stop and investigate. Late onset requires a full workup to exclude other things like urinary tract infections, appendicitis, cholecystitis, or even underlying neurological issues. If you only remember one thing from this entire explainer for your exams, please make it this. This is a grade A evidence exam trap. Ketonuria is completely misleading. It has absolutely no place in guiding your treatment or assessing hydration status. The guideline explicitly states that assessing urinary ketones does not have a use in management and should not be used to assess severity. Do not, under any circumstances, pick IV fluids based on a ketone dipstick. So if we're throwing out ketones, what should we actually use? Well, Grade C evidence recommends using validated scoring systems like the PUQE or HELP tools to objectively classify how severe the patient's symptoms are. The PUQE score, for instance, looks back at the previous 24 hours to classify symptoms as mild, moderate, or severe. It gives you a solid, evidence-based metric to guide your escalation of care. Let's move to Section 3, Ambulatory Care and Antiemetics. Once we've assessed the patient, how do we safely escalate treatments without harming the fetus? We have to move from first-line agents all the way to refractory management in a very strict, stepwise, logical order. And just as a note, the RCOG advocates heavily for ambulatory daycare, utilizing IV fluids and parenteral antiemetics in the community just to prevent unnecessary hospital admissions. When you're prescribing, you need to be confident. Backed by really robust grade A safety and efficacy data, you should boldly offer these first-line antiemetics. Patients are understandably terrified of teratogenicity, right? So it's your job to reassure them that the absolute risk is incredibly low and there's no increased risk of congenital malformations. Also, jot this down for your exams. Exonvia, which is a delayed-release combo of doxylamine and pyridoxine, is currently the only specifically licensed treatment for NVP in the UK. Now, when those first-line therapies fail, we step things up. Pay really close attention to these exam points. With ondansetron, Grade B evidence says we must counsel patients about a very small increase in the absolute risk of orofacial clefting if they use it in the first trimester. And for metoclopramide, Examiners absolutely love to test the risk of extraperinatal side effects. To avoid this, it strictly requires that intravenous doses be given via a slow bolus over at least 3 minutes, per grade C evidence. On to Section 4, Inpatient and Refractory Management. For patients who literally cannot tolerate oral fluids or are showing signs of severe malnutrition, what's the ideal intravenous fluid? Grade C evidence explicitly points to normal saline, so 0.9% NaCl, with added potassium chloride as the absolute gold standard. Because hyperemesis causes these profound shifts in sodium and potassium, administration has to be guided by strict daily monitoring of urea and electrolytes. For a persistent refractory HG, good practice points dictate that we should combine medications synergistically from different classes. If the oral route just isn't working, grade D evidence supports switching it up to parenteral, transdermal, or rectal routes. We really only utilize corticosteroids when standard therapies completely fail, although this is backed by strong grade 1+A evidence. Always schedule an ultrasound to confirm viability and rule out trophoblastic disease or multiple pregnancy, which of course drive up those hormone levels. Finally, a very sobering grade C recommendation: absolutely all therapeutic measures must be tried before termination of pregnancy is even considered. And finally, Section 5, Complications and Ongoing Care. We have to proactively manage severe complications. Listen up, because this is a massive, potentially fatal exam trap: Wernicke's encephalopathy. It's characterized by nystagmus, ataxia, and confusion, but it is a completely preventable medical emergency. Thiamine supplementation, usually as Probrinex, absolutely must be given before any dextrose or parenteral nutrition goes in. Giving dextrose to a thiamine-depleted patient triggers rapid neurodegeneration. Memorize this sequence for sure. Also, don't forget the downstream effects of all that severe, intractable vomiting. The guideline stresses that treating secondary gastroesophageal reflux with a proton pump inhibitor or an H2 blocker doesn't just heal the esophagus, it actively improves the patient's overall quality of life and actually lowers their PUQE scores. You've got to treat the whole clinical picture. As we prepare the patient for discharge, keep in mind that HG has an extremely high self-reported recurrence rate. We're talking up to 89% in subsequent pregnancies. But there's a silver lining. You must counsel your patients that starting antiemetics preemptively, before symptoms even begin in their next pregnancy, offers a really powerful grade B protective effect. It significantly lowers their recurrence risk and symptom severity. To wrap up this explainer, I'm leaving you with a clinical challenge for both your MRCOG exams and your daily practice. Knowing that this condition is driven by profound genetic and hormonal hypersensitivities to GDF15, how will you prioritize subjective patient distress over outdated, disproven metrics like ketonuria to fundamentally improve maternal care? Thank you so much for joining me, and best of luck with your exam preparation.